Let's review the Seldinger technique again in more detail as we walk you through the insertion of a central venous line. After carefully considering the need for a CVL, as well as the advantages and disadvantages of alternate sites, the patient is consented for the procedure where appropriate. Next, the following equipment should be assembled on a clean trolley in the bed space, which itself should be uncluttered, appropriately lit, and provide adequate access to the desired side of the patient. For the trolley, you will need the following: sterile drapes, gloves, mask and hat. Sterile CVL pack, which should include all necessary equipment for line insertion. Skin antiseptic, such as chlorhexidine. Large sterile drapes to provide a generous sterile field. Local anaesthetic, syringe and needle. Central venous catheter and needleless connectors. Either saline or heparinized saline to flush. Ultrasound with probe cover and elastic bands. Introducer needle, syringe, cannula where used, wire, scalpel and dilator, suture and dressing. In the past, central line insertion was guided by an in-depth knowledge of the surface anatomy of the target vessel. In today's practice, ultrasound is usually used to complement this knowledge. This is covered in more detail in a subsequent video in this module. The ultrasound machine should be located, plugged in, and orientated within the bed space to provide the best view in the operator's desired working position. Have a look at the vessel prior to sterilising the insertion site to ensure the machine is set up to provide the best image of the target vessel and surrounding anatomy and is not liable to cut out at the wrong time. The patient should then be positioned optimally. The operator undertakes the conditions for proper aseptic technique by donning the mask, hat, washing hands, securing the gown and gloves, and cleaning the patient with appropriate antiseptic solution. Due to the fact that chlorhexidine and povidone iodine solutions have their effect at the point of evaporation, the antiseptic solution should be left to dry completely before proceeding. Sterile drapes are then applied and fixed to provide a generous sterile field, ideally the total body length of the patient. The ultrasound probe cover is applied without compromising sterility. This takes practice, with our method being inversion of the sleeve, grabbing the ready gelled probe, sliding the sleeve over the probe, taking care not to desterilize, applying the enclosed elastic bands, and securing the sterile probe carefully to the drape with a clip to prevent it from falling from the sterile field or onto the floor, thus damaging the probe. Finally, you are ready to reassess the anatomy with the ultrasound, anaesthetize the area of skin both around the insertion site and the likely area of suture insertion, and it is at this stage that the procedure of inserting the central line can occur. Once the correct insertion point has been identified, the needle is inserted at approximately 20 degrees to the skin. The syringe should be aspirated as the needle is advanced, ideally under ultrasound guidance. Venous blood should be freely aspirated by about 4 to 5 centimeters. If blood is not aspirated, the needle should be slowly withdrawn, aspirating as you go. If access is still not obtained, reacquire the anatomy using ultrasound to redirect the needle and repeat. Failure to obtain venous blood after 2 passes should make the operator consider repositioning the patient and seeking senior assistance. Assuming confirmed venous blood is freely aspirated through the needle, the wire is threaded into the vessel. The wire should pass with minimal resistance. If the wire does not advance, withdraw the wire and ensure blood can still be easily withdrawn through the syringe, rotating the bevel of the needle if necessary. Failure to thread the wire despite these efforts should prompt the operator to seek senior assistance. With the wire in place, confirm placement on ultrasound prior to dilating. After making a small nick in the skin with the scalpel, thread the dilator over the wire using sustained pressure about 3 to 4 centimeters from the skin. There is often a slight loss of resistance as it passes into the vein. If the dilator doesn't pass, ensure the skin incision is large enough, the end of the dilator isn't frayed, and ensure that the wire hasn't been irreversibly damaged. After withdrawing the dilator and controlling bleeding, thread the flushed central venous catheter over the wire, taking care to retrieve the wire from the uncovered brown lumen. It is important to take care not to withdraw the wire from the vessel. This involves simultaneous forward threading of the catheter and removal of the wire. Ensure the central venous line is inserted to the desired depth prior to aspirating and flushing all lumens. Secure the line to the skin using the sutures at both the skin insertion and the hub. Different ICUs may have varying ways of securing lines, so check this with your unit. Cover with an appropriate dressing. High-risk patients may require a chlorhexidine impregnated line and dressing. Again, check your local guidelines. Lastly, ensure that the line is in position by performing imaging. All record of the insertion is documented, and your compliance with local infection prevention standards has been recorded. In summary, this module has provided an overview and some specific points on the general Seldinger technique used to insert central lines on the ICU. In the next video, we'll consider how this approach is applied at the 3 most common sites of insertion: the subclavian vein, the internal jugular vein, and the femoral vein.